The year was 2012, and a disgruntled orthopaedic trainee, that was me, had developed a severe case of assessment fatigue. There was a string of literature around the same time showing that both trainers and trainees had all developed a similar condition. There was just too much assessment, and the focus seemed to be on completing the assessment forms rather than for the purposes of teaching and learning. Here's an example of one of the assessment forms. It has so many fields, making it very time-consuming to complete. Having to do 40 plus of these a year was a big burden for little perceived educational benefit. To address these problems, we developed the generic operative supervised learning event, the GOSLE. It's got an expanded rating scale to make it easier to demonstrate progression. We stripped out a lot of the tick boxes and also made the feedback areas follow Pendleton's structure. We used Kirkpatrick's model to evaluate the GOSLE through a combination of quantitative and qualitative methods. To judge reactions, we sent questionnaires to a pilot cohort. The majority agreed that it was easy to use, and most preferred the GOSLE to existing assessment methods. To demonstrate learning, we found a very strong correlation between the seniority of the operating surgeon and the GOSLE score achieved. The scores were also very reproducible between assessors. To assess educational impact and behavioural change, we actually focused on the behaviour of our assessors. Feedback provided on existing PBAs was frequently absent, and if it was present, it contained mainly descriptive comments. For the same procedures, feedback on GOSLEs was mostly specific and actionable. The rating scale has now been adopted by the surgical training portfolio in the UK. Next, we hope to embed the GOSLE in the new surgical curricula.